The next topic, I should have introduced my faculty to begin with. We don't have Dr. Srinivas Joshi with us today because he's busy with other things. Dr. Guru Prasad was the person who just spoke to you. We have Dr. Apurva, his illustrious daughter, who will be speaking on don'ts in endophthalmitis subsequent to my talk. And Dr. Mahesh Gopalakrishnan, a renowned vitreoretinal surgeon at Cochin in Giridhar Sai Institute. He will be addressing the very important topic of medico-legal implications, how to mitigate and how to avoid in the first place. So now Dr. Guru Prasad mentioned in the last slide that every suspicious post-operative reaction should be assumed to be infectious until otherwise proved, which is also what I'm trying to emphasize. If you hear hoof beats, you will be commonly right if you think that it is horses and not think that it is zebras, although zebras also can produce the same sound. So the more commoner diagnosis you make in the case of endophthalmitis, you should err on the side of infection and not TAS. You should look for what is there in the eye rather than what is not there. Most of us try to console ourselves by saying the patient is not complaining of pain, there is no lid edema. Now these are all very, very soft signs. If the patient has impaired vision and there is increased reaction in the anterior chamber plus minus hypopyon, it is infective, and all measures to deal with that in that direction should be taken. So in that regard, I would just like to draw your attention to Murphy's laws, which in essence means that if a certain thing can go wrong, then it will go wrong. So you must be prepared. If you operate, there is a possibility that something may go wrong. So be alive and alert to that possibility. The other thing that I would like to draw your attention to is what has been referred to as the Kubler-Ross grief cycle. When we are confronted with a difficult situation in life, as in a patient who develops an increased reaction, the first reaction will usually be denial. We try to say, I've done a good surgery, it's unlikely that this patient has endophthalmitis. There's no way that this patient could have developed endophthalmitis. And then there is a little anger at some of our OT staff, maybe, did you do something wrong? Then you try to bargain with the situation, then you get into depression, and finally you accept. Now, this should be completely reversed. Acceptance should come in straight away in whenever there is a situation of an endophthalmitis. So, apart from the rigorous attention to asepsis at all stages of the continuum of the operative procedures, starting from cleaning, sterilization, preoperative preparation of the patient, intra and postoperative aspects, we must be very, very cautious about the preoperative careful assessment. All of us are so keen on knowing only one thing, how well the pupil dilates before cataract operation, but there are a host of other things that we should be looking at and not overlook. Obvious signs in the lids such as these are a no-brainer really, but if you have patients who present with this subtle foamy discharge at the lid margins here, it indicates a low-grade infection in the eyelids. Frank, frothy discharge at the lid margins are a big no-no for any cataract surgery. Look at this patient who had slight fullness of the lid on the temporal aspect, but if you avert the lid and see, you see these two pus points and in fact a streak of mucopurulent discharges there as well. So and the other set of photographs at the bottom, I was trying to draw your attention to the fact that if we examine these patients on slit lamp under high magnification, we may just be looking at this cornea, the cataract and the pupil, and we may not be looking at the lids itself. Whereas if you examine with a little lower magnification, an obvious audiolum that this patient has and the undulations along the lid margin, these things can be completely missed if you straight away go to a high mag and don't look at the adnexa beforehand. Also, patients who have undergone previous buckles may have granulomas in the fornices, exposed buckles or sutures, and these things may be overlooked if a proper history is not taken and all our attention is directed only towards the cataract. So draping is very, very important. It should be, you should ensure that all the eyelashes are properly tucked underneath the drape. Then 3 minutes contact with povidone iodine. There should be no compromise on this as well. What I also do is a thorough conjunctival irrigation, a pre-entry to try and physically drain away any pathogens that may be there. And then of course, trying to keep the AC well formed at conclusion. If the AC is not well formed, it is thought that there's a suction effect into the AC and that draws bacteria into the eye at the end of surgery. So keeping a well-formed AC with proper hydration of the wounds at the end is an important one of the do's in prevention of endophthalmitis. All of us marvel at our surgical skills and completely delegate the post-operative care to the assistants in our hospitals, or many times don't even bother about this. We had this patient who came in with hypopion on the third post-operative day, and this photo has not been taken just for the purposes of presentation here. All the hairs there were all getting into the conjunctival sac, and this was how it was. Now, what we have started doing is advising patients to wear, particularly women, to wear this kind of a hairband there, so that the hairs of the scalp don't get into the conjunctival sac and cause infections. The other point which I was trying to highlight is examining the patients in the lying down position is a big no-no post-operatively. Many times in hospitals, when there are multiple surgeries done, patients are examined with a torchlight in the lying down position, and if the subconj has been given, then the hypopion which is actually there may be layered out like this in a concave manner, and the overlying conjunctiva with a bleb there may be obscuring this hypopion. So we have to examine these patients in the sitting down posture and on the slit lamp. The other situation where early hypopion may be missed is when the patient has a prominent arcus. So those are some situations where these probably would have been relevant to Dr. Guru Prasad. Sniffing the enemy early, never examine in the recumbent posture, always examine in the erect posture and on the slit lamp. Be aware of an overhanging inferior conjunctival bleb related to a subconj given or arcus if the patient has one. The same patient with appropriate intravitreal injection. I was referring to this kind of a inferior chemosis of the conjunctiva. We will not go into this, you will see this chart probably even in Dr. Apurva's lecture. These are clues to tell you whether this patient has TAS or endophthalmitis. But broadly speaking, if there is a severe reaction on the first post-operative day without any corneal infiltrate, and the hypopion is not yellow but white with a fibrinous reaction in the anterior chamber, that patient most probably has TAS. And if the pupil dilates very well to your measures at dilating, that is, the pupil dilating freely well is another important clue to suggest that probably we are dealing with TAS. Now, coming to the management itself, it has been very well emphasized by Dr. Guru Prasad. What I would like to highlight is one should not sit back and say now the case has gone into the domain of the vitreoretinal surgeon and we can't do anything. The operating surgeon should look for perpetuating factors such as a wound leak, or if there is a side port which is too large and there is any track from there, suture abscesses. So these things can be addressed immediately along with intravitreal injections, which is not the domain of the vitreoretinal surgeon. It should become the domain of the treating the surgeon who operated on the patient first. We will discuss that a little later. These are some pictorial diagrams about how to take the anterior chamber and the vitreous tap. You raise a bleb of local anesthetic as shown here, and then methods at vitreous aspiration, either using a vitreous cutter, which is ideal, or you can passively try and get vitreous out with the plunger removed. If the vitreous happens to be liquefied, you'll get some aspirate in such cases. So these are some of the things that I was alluding to. Any provocative Siedel's test that shows a wound leak, track from the side ports, etc. And these are pictures showing that all is not lost in endophthalmitis. If you diagnose early and act promptly, endophthalmitis responds. Many cases respond very well to intravitreal therapy, which is really the first aid. And the other important thing is when diluting the samples for intravitreal injections, you must be appropriately gloved. You should not take it easy because, as you can see from the picture here, we will be touching the plunger, and if we do it bare hand, then a contaminated hand can contaminate this plunger itself, which will again be going into the barrel of the syringe. So we must use aseptic techniques in preparation of the injection and always refer to the charts in dilution. The faintest ink is better than the sharpest memory, they say. So always refer to the charts before you make the dilutions. So these are some pictures to show endophthalmitis that responded well to intravitreal, vitrectomy techniques. So prevention, as far as TAS is concerned, it's important to follow standard operating procedures in the whole gamut of the operation theater area. Regular health education of all paramedics and recalibrating the system on a regular basis is important. As far as endophthalmitis is concerned, an obsessive compulsive attention to asepsis, and one should be almost, as I say, obsessively compulsively attentive to any breach in asepsis that may occur. And the more we sweat during peace, that is, the more we sweat during our normal days, the less we may bleed whenever there is a situation of an endophthalmitis. This is the flow chart to show about how we should really go about handling patients with endophthalmitis. Initially, according to the EVS study, vitrectomy was useful only in a subset of cases, but nowadays, with improved instrumentation and better antibiotics available, the paradigm shift in the management has taken place, and we now tend to operate early. The other video which I wanted to show was how to take the samples from the anterior chamber. See, many times these patients will have thick fibrinous purulent material in the anterior chamber, which will preclude a view of the fundus in case we are taking these patients up for vitrectomy. So removing this provides material, improves visualization, and it also prevents zippering of the angle and recalcitrant postoperative secondary glaucoma. So you can see that it's really very thick, and you will see that the iris looks completely a different color and hue once you remove all this, and you can see how much of this is there in the periphery as well. Of course, you must be very careful not to strip off the Descemet's membrane in these patients, because the cornea will also be edematous, so you should be extremely careful in what you are doing and not pull something randomly. This is an unedited video which is just showing how much of pus is there in the anterior chamber, fibrinous membrane. In some it may be very obvious, in some others it may be a thin diaphanous membrane. Almost seems as if it's multi-layered. See, once we clear this, then the subsequent steps of vitrectomy in these patients becomes a lot easier. Again, more videos to show the same, and then we go ahead and do the vitrectomy, which again is a difficult procedure in many patients because of poor visibility, etc. That is not the subject matter of discussion really. And the other thing which I wanted to highlight is this. You drape the patients well, you put betadine, and then irrigate the conjunctival sac. And after appropriate dilution, if anterior segment surgeons are scared, you can use the hub of this 1 cc disposable syringe itself as a marker. Ideally, you should have a marker, but this is a good enough rule of thumb to use. You can place one edge at the limbus, and then the distal end will be where you enter the eye with a 30 gauge needle. You should always use a 30 gauge needle, because that is, in fact, in countries abroad, they're using a smaller gauge needle than that, but we have access to only the 30 gauge needle, so we must be using that and not a 26 gauge needle, because there will be a lot of reflux with the larger bore needle. After injecting, you go perpendicular to the scleral surface towards the midvitreous cavity, inject very gently to avoid any jet stream effects, and with the bevel facing the IOL, and then close with a cotton tipped applicator so as to prevent reflux. So those are some of the do's in endophthalmitis.